Good morning. Thank you for being here. My name is Kenta Fujio from Rian Clinic in Tokyo. Today I will share a clinical study on dual frequency monopolar radio frequency for the lower phase. We compare radio frequency along with a radio frequency plus HIFU, and we looked at how this changes with the patient's soft tissue volume. This is a retrospective single center analysis. I have no conflicts of interest. Okay, so first let me explain the device and how it works. This is monopolar radio frequency system. It delivers two frequencies at one same time, 6.78 megahertz and 2.0 megahertz. And it uses one applicator in one session. The main idea is bulk heating. It heats the whole dermis and subcutis together as one volume. The key difference from conventional 6.78 megahertz only RF is the 2.0 megahertz frequency. 6.78 megahertz alone reaches mainly to the dermis, so it does surface tightening. And when we add 2.0 megahertz, the heat goes deeper and reaches the deep fat layer. This lets us do three-dimensional volumetric tightening, which singular frequency RF cannot do. So why would we combine these two technologies? Let's compare how they work, deliver energy. So on the left is dual frequency RF. It makes a wide, even thermal fields across the dermis and subcutis. So this is very good for tightening, but alone it is not best for deep, dense tissue. On the right is HIFU. It is the opposite. It makes small focal coagulation points at exact depths. It reaches the smooth and deep subcutis, but it does not affect the tissue in between. So this gives strong lift and volume reduction. So the two are not competing. They are complementary. One heats in bulk, the other coagulates deep and focal. This is the idea we want to test. So this is the gap we want to fill. Monopolar RF and HIFU are both well studied on their own for non-surgical facial examination, but we do not have good long-term data on combining dual frequency RF with HIFU. The critical question is this simple. In which patient is RF alone already enough, and in which patient does adding HIFU really makes a difference? Patient selection is the main focus. So this design is simple. This was a retrospective single-center study of 29 patients. All had follow-up longer than 60 days. We had two arms. Arm A, 24 patients treated with dual frequency RF monotherapy, and Arm B, 5 patients treated with dual frequency RF plus HIFU. The primary endpoint was changes in between in lower face volume. We measured it with vector 3D photography, and we stratified the results by soft tissue volume. And we used age 40 and over as a simple proxy because this is a group where the tissue support starts to decline. So here's the baseline characteristics briefly. For all 29 patients, the mean age about 44 and a half years. Most were female. The median follow-up was 170 days. So these are real long-term results, not just early results. So now the results, I will go region by region. So on each chart, the taller bar means more volume reduction. So taller is better. So first I will show the whole group. Then I will split by age. So let's start with the upper cheek. In the whole group, RF monography gave a reduction of 1.08 cc, and adding HIFU gave 1.37 cc. So the extra benefit is about 0.29 cc. So in the whole group, the combination is a little better in the upper cheek. So next, the lower face, the periorbital region. Still in the whole group, RF monography gave 1.42 cc. The combination gave 1.55 cc. So the extra benefit is about 1.13 cc. So in the whole group, both region looks similar, both protocol works well, and the combination is a little better, but the average numbers hide the important point. So we can see it clearly when we split by age. So let me show you. So now we look at only at patient aged 40 and over, the group with more soft tissue volume. So again, we start with the upper cheek. So RF monography now gives 1.27 cc. The combination gives 1.37 cc. So adding HIFU did produce a change, but the gap is small, only 0.1 cc. So for the upper cheek, dual frequency RF alone is already very effective, even in the older patient. Adding HIFU helps a bit, but the difference is not large. So please remember this because the raw face is different. So this is a key result of this study of the raw face in patients aged 40 and over. Here, RF monography drops to 1.24 cc, but the combination stays at 1.55 cc. So the extra benefit is about 0.31 cc, the largest in this study. So the pattern is the opposite of the upper cheek. In the raw face, with soft tissue volume is higher with age, RF alone is not enough. This is exactly where adding HIFU helps with muscle level progression and rear rift. So let me show you two representative cases. And case one is a 44-year-old woman treated with dual frequency RF monotherapy. These are the vector images at 6 months follow-up. So even with monotherapy, the jawline is clearly sharper, and the heaviness along the raw face is much reduced. The facial contour looks tighter and more defined. So this is a typical patient where RF alone gives an excellent durable results. So case two is a 41-year-old woman treated with RF plus HIFU. These are the image at 4 months follow-up. Here we can see the added volume reduction from HIFU. The nasal fat and the jaw fat are further reduced. So, and because HIFU tightens mass, we also get a clear lift-up effect along the jawline. So compared with RF alone, the combination gives a stronger and straight lift on top of the volume reduction. So what does this mean? This means message is this: bulk heating and focal coagulation are complementary, not competing, and the right choice depends on the region. So in the upper cheek, dual frequency RF monotherapy gave volume reduction similar to the combination, even in a patient over 40. So here, RF alone is relatively enough. So in the raw phase, the result is different. The combination was clearly better than RF alone in the older groups. So HIFU adds mass and retaining ligament tightening, and this gave the real lift-up effect. This matters most in the patient aged 40 and over, while the ligament support is weaker. So there are some limitations. So first, there are small sample size. The overall cohort was limited, and the RF and HIFU combination group was especially small, n equal 5, so reducing statistical power for the combination arm. So number two is the sex imbalance. The cohort was almost female, 27, 29, so which limited how the findings generate across sexes. And the three, this is a retrospective design, so user proxy for the soft tissue volume may induce selection bias and unmeasured confounding. So to conclude, the simplest way to remember this is match the protocol to the region and add HIFU where lift matters. So for the upper cheek, the dual RF frequency monography is enough, but for the lower face, in patient age 40 and over, add HIFU for mass level support ensures the combination is the best for the patient over 40, with raw phase concerns. RF monography stays the best choice for the mid phase. So thank you for very much for the attention.
I have a question. Can I ask you a question? Yeah. So my question is, if we see only volume reduction,
Okay.
do you feel, or what is the theory behind it? Do you feel that it dissolves fat, decrease fat, or it's changing the location, but then I should have expect somewhere increasing in volume? So what is your theory behind decreasing amount of volume? Is it dissolving fat?
Yeah, I think so. Especially HIFU, like the temperature is very like 65 or around 70. I think it's like induced volume reduction, like apoptosis. So
But you saw also volume reduction only with RF.
yes, with RF, but I think it's RF is not enough for the apoptosis because
So why? Why there was volume reduction? Where did the volume go to?
I think it's not volume reduction, but it's tighten the soft tissue volume, and then the result looks volume reduction, but it's in reality just the fat volume fat just tighten and looks volume reduction, but I think it's not apoptosis in the only RF cases.
Thank you.
Thank you.
Okay, morning everyone. I'm Dr. Arash Jalali from Canada, and I am 88 years old. No, I'm not. But if you listen carefully, when you're 88, you might still look like how you do now. So I'm going to talk about something quite different, systemic approach to aging skin, which a lot of you probably don't know about, or maybe some do. I have no disclosures for this talk. The real question is, why do we age? Whether it's a spiritual, philosophical, or scientific process, doesn't matter. But the key thing to understand is living longer is not always living better. Therefore, the whole challenge nowadays in our field is how we can maintain and improve a good quality of life while increasing the lifespan. And for that, we need to understand that aging is a system failure. It's not a single defect. A lot of us have been focusing on skin, but we forget about everything else, and that there's actually an intertwined connecting axis between every organ that we have in the body. So in my opinion, longevity medicine works best when we restore communication between all of these organs together, not in isolation. Aging, we know it's a natural, unstoppable process. We can't stop it, contrary to what a lot of people might think. It's a cellular and molecular matter. And it's a result of two things. Number one, reduced capacity of our immune system, which we call immunosenescence. And obviously, if our immune system is not functioning well, we're going to have an increase in inflammation called inflammaging. But the ultimate goal, essentially, then, is to reduce our inflammation by increasing or strengthening our immune system. Easy, you might say. For that, we need to understand what autophagy is and its role in the disease. Autophagy, think of it as a cellular recycling system where the body can actually recycle the overused cells and make them all new again. Rather than going through apoptosis or cellular cell death. Sadly, this process is impaired with normal aging. But it is upregulated in caloric restricted state. And so the first thing I want to talk about when it comes to systemic approach is caloric restriction and intermittent fasting. Something as simple as fasting for a period of time, it has shown to actually reduce levels of tumor necrosis factor alpha and other inflammatory markers in the blood. And recent studies suggest that both caloric restrictions or intermittent fasting seem to be effective when it comes to that. The first drug I want to talk about is metformin. A lot of you have heard of metformin as a diabetic drug, but maybe yes, maybe not. We're starting to think that the metformin actually is not a diabetic drug, but one of the effects that it has, it's control of blood sugar, and so it can be a beneficial agent when we use it in diabetes. But generally, the medication has a lot more benefits. And why is that? Because we have research showing that the benefits is not even it's not just in diabetic patients, but also in the non-diabetic controls when it comes to cardiovascular disease, when it comes to aging-related decline, and even certain cancers like gastroesophageal cancer, for example, or prostatic carcinoma in men. What do we think about metformin and longevity, or why is it actually effective? Well, in 2014, we had the MILES trial, and this was the first direct evidence that metformin actually modulates metabolic and non-metabolic gene expression linked to aging. So it's not just working at the surface level. It works at the DNA level, and that's why it can be effective. How does it do it? By directly targeting the mitochondria. We all know about mitochondria, it's a powerhouse of the cell. And essentially, it reduces anabolic pathways and elevates catabolic pathways, and that's how it can trigger autophagy that I discussed a bit earlier. Another thing that metformin does is indirectly it inhibits mTORC1 activity. I don't know how many of you know what mTORC1 is, but mTORC1 is essentially, think of it as a gateway, a door that you open to multitude of diseases, illnesses, and eventually death. I'm going to talk a little about mTORC1 later on, but think of it, mTORC1 is bad, essentially, when it comes to longevity, and metformin has a way of turning it off. So this is just a representation of what I just mentioned. Increases AMP kinase activation, thereby reducing mTOR activity and extended longevity, and also autophagy activation through increasing catabolic pathways. Medication is essentially really safe. We talk about adverse effects. These could be adverse effects, but really these are nothing. And if you start the medication at low dose and gradually titrate up, I don't think you're going to have any problems. The only thing is lactic acidosis in patients that already do have abnormal renal function, so you want to be careful with those. So why am I talking about drugs? Why am I talking about metformin, you might ask? Well, I think that skin is a mirror of systemic aging. When you have high cellular turnover, it doesn't matter where, whether it's in your gut, in your brain, anywhere, you have early signs of mitochondrial dysfunction as a result. And as a result of that, you're going to get that immune dysregulation. Inflammation is going to go up, and then the skin, dermal matrix breakdown will happen in the skin. And something else we've all heard of, NAD. You all have heard of NAD. NAD is gaining a lot of momentum these days. That leads to NAD plus decline levels, and that in turn will lead to impaired repair, barrier dysfunction when you're talking about skin. So this is how everything is related from inside to outside. How many of you do NAD injections or take NAD? Anybody in this room take NAD? You do injections? Okay, anybody else? You do injections? Okay. You should stop doing it. Not that it only doesn't work, but you're also increasing your pro-inflammatory pathways in your body. So it's actually ineffective. Why is it ineffective? Think of your car battery dying, okay? You might either buy a new battery, or you might just jumpstart the battery and it lasts for a few hours. That's what you're doing with NAD+. The reason for that is NAD+ levels in the plasma are not supposed to be elevated. And when you give yourself IV NAD, where's it going to go? It's going to go into your plasma. It's not going to get into your mitochondria. And so by doing that, you're actually increasing the pro-inflammatory pathways in the blood. So it's actually detrimental, I would say. If you do it chronically for a long period of time, it's not beneficial. I'm not going to go through the direct pathways of why it can be detrimental, but just remember that it cannot work. Furthermore, research shows that the levels are quite dynamic. They're influenced by diet, activity, circadian rhythms, even how well you sleep. And so studies show that short-term fluctuations in the NAD+ levels in the plasma anyway. So after you give yourself the IV, within 2 hours or so, the NAD+ levels are going to go back to what they were before. So if they were low before, it's still going to be low. If they were moderate, it's still going to be moderate. It has nothing to do with what you do IV or oral. And one thing, though, shows that a precursor of NAD+, which we call NMN, and all of you have heard of it, NMN in preclinical studies shows that it can actually increase the level of NAD+. Why? Because it can actually get into the mitochondria, and it can actually be converted through phospholipid oxidation to NAD+. Furthermore, we've had some studies showing that essentially when you do take the NMN supplementation, the NAD plus levels in our immune cells, or essentially the primopoietic mononuclear cells, can actually go up. And this is telling us that the elevation in the levels of NAD plus is actually very tissue dependent. So it's not going to go up in all tissues, but in some. Wow, I only have 4 minutes left. So I'm going to skew it up a little bit. We have studies about gut health. We have studies about sleep regulation and quality. As I said, circadian rhythm getting disrupted, it actually does affect your NAD plus levels. What about vice versa? Well, taking NMN seem to help sleep quality and sleep regulation as well. So it's vice versa. We have some studies about telomere lengthening. And at the end, we do have very limited human studies showing both efficacy and safety of taking NMN oral supplementation up to 900 milligrams daily. The other thing I want to talk about is rapalogs really quick. So rapalogs are mTOR inhibitors that directly do this. Remember the mTOR that I talked about earlier? Rapalogs are actually cancer drugs. We give them to patients with renal cell carcinoma. But studies show, both preclinical and clinical studies, that if you're using a low dose for a short period of time, you can actually have a beneficial effect where it stops the mTOR C1 and sort of closes that gateway to apoptosis or cellular death. Interestingly, females typically benefit more than males when it comes to this. And unlike caloric restrictions, which is a lot less effective when you start it later in life, it's not too late, but it's just less effective, rapalogs don't seem to be that way. So you can start at any age and you can still get the maximum benefit. What about the clinical trials we have? We've had some very limited clinical trials. So a 6-week study in elderly population showed upregulation of antiviral gene activity through mTOR C1 inhibition. We have a subsequent 16-week study, which is almost 4 months, doses as low as 0.5 milligram once daily or 5 milligram once weekly, having the same positive effect. Remember, it can have adverse reactions. This is a serious drug, so if you're considering it, you got to really be comfortable with it. If you are taking too much, or if you are taking for a prolonged amount of time, you're going to actually inhibit a sister enzyme called the mTOR C2, and that is bad. That's mTOR C2 is a good thing, so you don't want to stop mTOR C2. So think of all the bad things that can happen. Basically, your skin can start to break down. You can have mouth ulcers. You can have GI issues, healing, and of course, immunosuppression, which is really bad. Skin rapalogs, we've been using topical rapalogs in skin already for a number of decades, actually. We've been using it in tuberous sclerosis, for example. And research shows that not only you don't get any detectable levels in the plasma, so it's quite safe, but also you get increased collagen 7 production and histologically an improvement in the skin appearance. This is just another representation of what I talked about. I'm just going to briefly touch base on vitamin D. I only have a few more slides left and then I'm done. Vitamin D, a lot of people think of it as a hormone, actually, and I think it's both a vitamin and a hormone. Why? Because it has both anti-inflammatory and immune modulating effect. So why is it good when it comes to anti-aging, when it comes to skin? Because most of our immune system cells seems to have something called vitamin D receptors. So if your vitamin D level goes down, guess what? Your immune system is not going to function properly. And we have numerous studies about what is the normal level of vitamin D or how you can achieve that. And let me tell you, majority of people on humans on Earth are vitamin D deficient, so you must take it. Even people in Florida. So we have studies on people in Florida where there is abundance of sun and they're still vitamin D deficient. We have studies dating back to 2023 suggesting that vitamin D can actually reduce inflammation in the skin and actually improve the skin barrier repair and slow the degradation process when it comes to normal aging. Lastly, I want to talk about caffeine. How many of you drink coffee? Yeah, all of us, right? It's the #1 drug in the world that we're addicted to. And guess what? It's actually really good for you, so don't stop. Caffeine, coffee consumption seem to be inversely associated with total and all-cause mortality. There was a very long 10-year study in the New England Journal of Medicine about 10 years ago, and the evidence was that drinking a couple cups of coffee can be linked to a longer lifespan. We had a follow-up study in 2022 that essentially confirmed the same thing. And recent publications suggesting that oral dietary supplementation of polyphenols, essentially caffeine has a lot of polyphenols, it has demonstrated an effectiveness when we're addressing skin photoaging. So I tell all my patients to drink coffee if they don't. In closing, I just want to mention, even though we talk about aging and how our field is changing, aging is still not a disease. So we can't really, code patients and say, okay, you're diagnosed with aging, which all of us are, and then this is a treatment. But what is clear is that systemic therapy is not just anti-aging, it is pro-longevity. And I believe that everything starts from within. Renewal should start from within. Why? Because all the systems are interconnected. So even though aging may not yet be a disease, but I think the decline in biological resilience is, and resilience is something that we can influence by the treatments I talked about, and a lot more upcoming through the clinical trials and the research that we have. Thank you.
Good morning, everyone. I'm Dr. Joseph Andre Bangalo from the Philippines. I'm an aesthetic medicine physician. My lecture for this morning is Prejuvenation. Is it a Gen Z thing? Here are my disclosures and the objectives for today's lecture. So what is prejuvenation? These are treatments before the visible signs of aging appear. So these are non-invasive treatments mainly for prevention. Studies show that as early as 18 years of age, we're starting to lose 1% of collagen annually. For us Asians, visible signs of aging appear around mid-30s, but this is not what's happening in real life. In the clinics, we see patients in their 20s, but they look way older than their age because of external factors. So the term prejuvenation was also coined by this group called Gen Z. Who are these Gen Z? Born between 1997 to 2012, and these patients are from 14 to 29 years of age as of this moment. So if I look into my private practice in the Philippines, 42% of my patients belong to this Gen Z category from 14 to 29 years old. And what are the common concerns of my patients in this age group? So these include acne, large pores, hyperpigmentation, oily skin, dry skin, and the skin not being nice. So it really depends on how they define what nice is. And in terms of medical grade skincare treatments that we recommend to our patients or we perform in the clinic, we start from the non-invasive going to the minimally invasive. We prescribe medical grade skincare, perform energy-based and laser treatments, skin boosters through mesotherapy, and lastly would be injectable treatments, especially for those who truly need them the most, like Botox, fillers, and threads. But what we want to introduce something that is in the middle. No needles involved, but can give similar results with the usual mesotherapy and skin boosters. So let's look back at the definition of skin booster. These are biological materials or bioactives that help or encourage the skin to increase or improve its function. It can be used to treat the loss in skin nourishment and vital components, which is the concept involved in the biorevitalization of the skin. So usually they're given through mesotherapy, whether manual or injector machine. So these are your hyaluronic acid, exosomes, polynucleotides, PDRN, PDLLA, PRPs. So the question now is needleless skin booster possible? So yes. So the first one we will be talking about would be spicules. So what are spicules? Spicules are fine structures extracted from the bones of hydrolyzed sponges. They appear as needles under the microscope with lengths ranging from 100 to 300 micrometers. And these needles are usually hollow, which are mainly composed of calcium carbonate and silica. These are freshwater sponges in origin, very fine particles, around 1/5 the size of the pore on the skin and 1/16 the size of your derma roller. They can deeply penetrate the dermis and activate microcirculation. So basically, it's the papillary dermis, and can stay inside the skin for 72 hours to produce skin regeneration. It has a pH of 6.5, which is closer to the neutral pH. Thus, there's really less skin irritation if we're talking about the spicules per se. So how do they work? Spicules work through exfoliation. So it's for skin renewal and regeneration. It has also anti-inflammatory and antibacterial properties, and for sebum control. They can be used as a form of the liver system as well. They are chemically stable and can be combined with active ingredients like your hyaluronic acid, niacinamide, vitamin C, or even salicylic acid. So the general application of spicules. So we clean and extract if there are comedones in the patient. We mix the spicule with a recommended solution. So what's common in the Philippines right now is like spicules combined with a 0.5% beta hydroxy acid, or a spicule that is already coated with retinol and mixed with vitamin C or niacinamide. Then we mix the spicule with a recommended solution and then apply the spicules all over the face using a spatula or a syringe. So usually I use a 1 cc syringe to mix the spicules with the solution, and then put tiny solutions all over the face, and then spread the spicule by pressing it into the skin. And then after that, we can apply serums, masks, and sunscreen after. So the spicule treatment aftercare, we apply sunscreen after. We tell the patients to avoid saunas, strenuous activities, smoking and drinking. We can wash the face after 12 hours after the treatment, but we ask the patient to avoid rubbing the skin because they will still feel the sensation of pricking sensation in the skin for the next 72 hours. They can gently wash the face with water, and they can use regular cleanser after 24 hours. They can use or resume to their skincare regimen, but with caution. The sensation of the treatment may last for 72 hours since the spicules are expelled after 72 hours. There's temporary dryness, and especially if the spicules are combined with salicylic acid or the ones that are coated with retinol. And then they can apply moisturizers after. The second common needleless skin booster in the Philippines right now is carboxytherapy. So carboxytherapy is a non-invasive CO2 procedure that integrates the principle of Bohr effect, which is applicable as a universal pre-procedure booster program or regeneration program without the use of needles. So how does it work? So as the concentration levels of the carbon dioxide increases in the skin, blood vessels, or capillary loop, the concentration of decomposed oxygen also increases. So when the CO2 absorbed in the skin enters the blood vessels, the oxygen in the blood vessels are released back into the skin tissue, resulting in an increased level of oxygen in the tissue cells. So usually, there is a carbon dioxide gel applied onto the skin, and then there is a carbon dioxide mask, which is like an activator. So once it is pressed into the skin, the carbon dioxide goes deep into the dermal capillaries, and then the excess oxygen from the capillaries will go back into the skin. So that is the Bohr effect. So again, that is the concentration and levels of the CO2 increases in the skin, blood vessels, or the capillary loop. The concentration of decomposed oxygen also increases. When the CO2 absorbed in the skin enters the blood vessels, the oxygen in the blood vessels are released back into the skin tissue, resulting in an increased level of oxygen in the tissue cells. So please do not be confused with the reactive oxygen species or the unstable oxygen containing molecules like your superoxide dismutase or hydrogen peroxide that can cause destruction of the collagen. So the indications of carboxytherapy would be skin regeneration, like pore reduction, skin brightening, and facial lifting, enhanced elasticity, acne improvement, reducing fine lines, reduction of subcutaneous fat, and improvement of stretch marks. I think in the Philippines, like 15 to 20 years ago, carboxytherapy was mainly used for the body for the stretch marks improvement. But right now, it is now being used for anti-aging purposes or even for prejuvenation purposes. So the combination treatments with carboxytherapy. So it can be like your pre-treatment before skin booster treatments. It can be a pre-treatment before acne management procedures. Post-procedure for swelling and bruise care. So after a liposuction, lipolysis treatments, or even laser that can cause bruising, you can use carboxytherapy. Post-procedure after lifting procedures like your HIFU and RF, you can also do carboxytherapy. So again, the general application of carboxytherapy: cleaning the skin and extracting if there are comedones. Apply the CO2 gel and activator mask. Apply pressure over the treated area. That's why it looks like a mummy. So we wrap the patient with elastic bandage so that there would be a continuous pressure all over the face. Incubation time, we let that stay for around 10 to 15 minutes, and clean the area after, apply serums, masks, and sunscreen. So the key takeaway for this lecture: good skin starts before the use of needles. Thank you so much. Have a great day, everyone.
Click here. Okay, thank you.
I think there's a PPT problem with registration, so I'm gonna start just with my cell phone. Okay, no problem. Okay. Okay. Good morning, everyone. I am Dr. Min Jae Park from South Korea. Okay. This is not exact PPT, the afternoon PPT. This one is the afternoon. I have the 4 p.m. Session is this one. So I think there's some kind of confusion. So this one is not this one. Okay. 4 p.m. Sorry. Okay. This subject is a PRF, and the PRF is some popularity, have some popularity in South Korea because PRP and PRF are okay. This is not. Okay. No problem. I have I gave presentation, 2 presentation, and morning session is for the activated PRF, and afternoon session is for LBS. I have take some time for your presentation.
Sorry about that. We will still figure it out.
So I think PLF is have some popularity in South Korea, and PRP is old school. So many you guys know that many Korean doctors always seeking the new technology, new kind of thinking. Every night, every day, we're thinking about the new one. And PRF is some kind of gain some popularity in South Korea in currently 2025 or 2026. And so I think we're some PPT. Sorry about that. So okay, I'm gonna present with my cell phone. Okay, no problem. Cell phone with because I have some. No, is it possible? Okay. Great. Okay. That's good for our colleagues. Yes. Okay. Okay. Thank you.
Sorry, everyone. So his sections will start again at 12:34. So that will be Dr. Park. Dr. Park Min Jae will speak again. But now we will move on to Dr. Erich Guy. But he will start in 5 minutes. So now if you want to take a break or go to the restroom, feel free. And we will start in 5 minutes again. Yes.
So which number?
You want to check your ticket?
Sorry.
It's system now. Just fix the clip.
Okay. So good morning, colleagues. I'm happy to be here and to present to you one of the studies that we've done recently. My name is Guy. I'm a medical doctor. I practice aesthetic medicine in Israel. I have 2 master's degrees, and I work both in the plastic surgery department, in the genetic institute, in the dermatological unit, and I'm working with a lot of patients. And when I'm looking on all of my patients, they have something really in common. And this is why I think that non-ablative fractional laser, as you will see in a few minutes, is so critical in every aesthetic and dermatological practice. You will see it in a minute. And this is why we studied it. And the changes that occur with non-ablative fractional laser during the last years are dramatic. And you will be exposed in a few minutes. And this is the question, and this is one of the biggest messages that I want to ask you guys. Because what is the role of non-ablative fractional laser in 2026? This is not new technology. And the question that you should ask yourself is, does we have any place or position for non-ablative fractional laser in our practice in 2026? And my answer to you is, of course, we have. We have because in 2026, no one wants artificial look. No one wants to be overfilled. No one wants fillers. No one wants botulinum toxin. These products, I like them. But we know today that our patients are educated and they are looking for skin remodeling. They are looking to change their skin. They are looking to make their skin healthier. And non-ablative fractional laser is the go-to. This is the tool for remodeling because it's cover all skin layers with enough volume. If you are using in your clinic CO2 laser, erbium YAG laser, it's good. You are doing remodeling, but really superficial. If you are using in your laser in your clinic HIFU, monopolar RF, it is good. But again, it's too deep. It does not create good remodeling of the epidermis and papillary dermis. And if you are using fractional RF microneedling, yes, you are doing good remodeling all skin layers, but not enough volume. So non-ablative fractional laser is the only way that you can remodel all skin layer with enough volume to create meaningful changes. And this is already proved. When I'm looking back on the literature on 1550 nanometer laser, the epidermis is remodeled. We see ECHOC protein changes, upregulation of differentiation marker. We even use 1550 nanometer laser to treat actinic keratosis, which means that with non-ablative fractional laser, we can remodel the epidermis. Maybe we can even prevent skin cancer. And this is what we are doing today. You will see it later. Because the epidermis remodeling is important. But what about the dermis? Producing collagen is not enough. Because we know that even scars can have a lot of collagen. It doesn't mean that it is a healthy skin. So fibroplastia is not enough. But reorganization, destruction of old collagen, production of new collagen, reorganization of new collagen to treat scars, to even prevent scars. 1550 is doing it. We are using it for that for a long time. Immune system. We know that with age we see chronic inflammation, right? We call it inflammaging. So without modulation of the immune system, we cannot remodel the skin. 1550 nanometer laser does it. We know that it decreases inflammatory marker and increases regenerative marker. Similarly, with vasculature, yes, it remodels vessels, it changes, it creates new vessels that are oriented properly. So we know that in order to get this effectiveness, we need to increase our energy, increase our density. Otherwise, we will not be able to cover enough volume. We said it's all about volume. Otherwise, we can use other technologies. But the problem when we are using high energy and high density to increase effectivity is that we also get complication. And this is why non-ablative fractional laser, although it's not new technology, it is not well used today. Because in my clinic before the novel non-ablative fractional laser, I had to choose. Either I use soft parameters, and then I have no complication, but also I have no result. Or I use aggressive parameters, then I have result, but I might have complication. And this is what changed during the last decade. That we know today that we can distribute energy different in the tissue. And this novel device, produced just now, launched just now, is able to do new things. It's able to distribute energy differently. Because its 3D mode allows you to combine 3 different fluency in one shot, in high density. Thereby, we increase effectivity because we have high volume, multi-layered, but also increase safety because we don't do overlap. We don't need to increase the chance for PAH and PAE. And we checked it. We did a retrospective study with all of our patients, and this is what we saw. Improvement in all skin parameters with no complication. Wrinkles are improved, evenness of the skin is improved, also pores and oiliness, everything improved objectively, not only subjectively, and we had 0 complication. Not only we didn't induce PAH, we treated PAH with non-ablative fractional laser 3D mode. All of our patients had their pigmentation decreased. So we are confident that with every skin Fitzpatrick, in every position, in every patient, in every age, non-ablative fractional laser creates remodeling. And it decreases inflammation and improves scarring. And this patient was suffering from inflammatory scarring, which means that the scarring did not heal well. But after non-ablative fractional laser, it changed completely. And this is what is the power and the role of non-ablative fractional laser in the clinical practice. It is the only way to remodel the skin effectively and safely in all skin Fitzpatrick to prevent aging and to treat aging. But with a novel technology, we can also do it safely. And we took this study further because we wanted to check this novel technology 3D mode in order to see if it creates change biologically, not just clinically, not just improvement of skin quality characteristics, but also the biology. And we wanted to check it out because with high energy, we can induce different changes in the tissue. So we took this novel technology, the 3D mode, and we checked it on mice. First thing that we did is review of energy distribution when it touched the skin, laser skin interaction, and this is what we saw. We saw that non-ablative fractional laser is not a non-ablative technology. This is wrong. There is no dichotomy anymore. It's not that either it's ablative or non-ablative. We did it in the Danish Skin Cancer Research Center, which was in Denmark under the guidance of Professor Hedersdal, which I learned a lot and I admire a lot. And what we saw was amazing. And this is what you will see in front of you. First of all, non-ablative fractional laser can behave as semi-ablative. When you use high energy, high fluency, when you're looking with LCOCT, you see changes of skin characteristic and laser interaction, which means that we see microscopic debris and it reacts like a semi-ablative procedure. And thereby we can also use it as a laser-assisted drug delivery and have some resurfacing effect. But second thing that we did is we checked it on mice. Why we checked it on mice? I don't know if you know, but hairless mice are very, very unique. Their senescence is much faster than human. Every 2 days of exposure of UV for hairless mice equal to 1 year of UV damage in human. So we were exposing them for 1 month to UV damage. And when we understood that, we created enough UV damage like our patient when they're coming to our clinic. We divided them into 2 groups. One group, we used this novel technology, 3D mode, just 1 pass every interval, every 1 month in the beginning and then 3 months. And second group, we didn't do anything. Then we kept expose them to the sun. And the reason is because our patient do not listen. We will tell our patient do not be exposed to sun, put sunscreen, but they will not do it. And they will expose to sun. And we wanted to mimic a real life situation. And what you will see in front of you is illustration because we didn't publish it yet. But this is what we saw. We saw that the mice that were treating with this novel technology did not develop skin cancer. They developed much less wrinkles and pigmentation, and their skin quality was much better. So we took biopsy. And this is what we saw. When we're looking on the genetic expression and the senescence marker after just one treatment, every interval, every 3-6 months, maybe in human, we see that the senescence is much, much lower, closer to the newborn mice than to the photo-damaged mice. And this brings us a really important question. Are we using now the technology as we should use? Are we use the technology only as a treating strategy? Or maybe we can use it as a preventive strategy? Maybe we can take our patient with a specific interval, treat them with non-ablative fractional laser, just one pass, multi-layer remodeling, and prevent their aging, prevent senescence, prevent skin cancer, prevent scars. And this is what we are doing today. We went into the human trial, and we are looking on this specifically. So we know today, non-ablative fractional laser is unique. It can be non-ablative, and it can be semi-ablative. Moreover, we understand that it decreases photo damage, but maybe prevent photo damage. So I invite you to explore it further and come and see the new technology and how non-ablative fractional laser have progressed. Thank you for listening.
Okay, nice to see you, everyone. I'm Dr. Shinji Noda from Tokyo. So I've been using a needle-free jet injector for 2.5 years in my practice, and it completely changed the treatment landscape in my clinic and also the treatment ways in Japan in general. So we'd like to introduce this new concept to you. So I'm from Tokyo, and I've been running my own practice for around 7 years. And I've been using this device for 2 years, and now there's a very high demand for acne scar treatment and also for pore size reduction. So that's the reason why I'm using 2 devices in one practice. So I'm the number one user of this needle-free jet injector and have been experiencing around 10,000 cases already. So this concept is widely available in Korea and Japan, but in Thailand or in some Asian countries, it's not that well known. So I would like to introduce my cases later. So this is the concept of a needle-free jet injector. Actually, yesterday I saw this kind of concept in SCAR sessions frequently. So now this concept is also used in other countries such as India or Taiwan. So we can inject any type of solution without using needles. So with a high-speed jet, there's a concept. With a high-speed jet, we can inject any type of solution into very superficial layer. So usually, compared with the needling technique, we can target the very superficial layer. So it's a very good fit with rejuvenation and also for the scar revision. So with a jet injection, we can create a controllable, very tiny damage to the skin and can regenerate the skin without so much downtime and risk. So only with a normal saline jet injection, we can achieve some rejuvenation effect. But we can also use any type of solution such as PDLLA, PCL, or CAHA, and also we can enhance the regeneration process. I frequently use a PDLLA for scar revision or kind of general wrinkle reduction, and also PCL for pore size reduction. So it depends on the indication. We can choose any type of material depending on your practice type or indications. So there's histological data which says there's a proper intradermal injection with a needle-free jet injector. As you can see here, there's a PDLLA deposition in the superficial dermis. So they are commonly used materials together with a needle-free jet injector. So I think the PDLLA is most widely used in Korea and Japan. So I usually use a PDLLA for atrophic acne scar revision and also for wrinkle reduction. But for pores, I tend to choose, yes, PDLLA also works with a needle-free jet injector, but I noticed that PCL can more widely spread out inside the skin, and also it has some function to suppress sebum production. So that's a very good treatment for pore size reduction. And for pigmentation, you can choose any type of anti-pigmentation material such as PDLLA or also the tranexamic acid or glutathione. And for hypertrophic scar, you can choose triamcinolone or botulinum toxin. Also, we can jet inject these kind of products. And also, it's applicable to hypertrophic scars and keloid. For skin firmness, we can inject collagen injectable or PN. And also for hair loss, we can inject exosomes, minoxidil, or also PDLA safely. So we can say this kind of needle-free jet injectors are very versatile and can correct any type of aging features and scars. So let me share my cases. Actually, for yesterday's session, I already shared several cases. So we'd like to introduce the new cases. So this is a kind of guideline for acne scars. So for aspic scar, gold standard is TCA cross, and also for rolling scars, subcision is a gold standard. But for TCA cross, especially for Asian darker skin type, PIH or prolonged redness is a concern. So I frequently use a needle-free jet injector to correct small, well-defined scars. So this is a technique. So we can hit each scar one by one. Usually I use 2 to 3 passes of this procedure. So the endpoint is some whitish elevation plus some pinpoint bleedings. So this is the result. With 2 sessions, you can clearly see that there's an improvement in ice-pick scars and also for box scar scars. For these kind of types of small, well-defined scars, this technique works really well. Again, this is a 1 session. This is a kind of regular result with 1 session. But if we use this technique repetitively, we can improve the scars much better. So these are the box scar scars on the glabellar area. I used the TCA cross first for multiple sessions. It worked, but it stopped working. So I started using a needle-free jet injector, and there was actually better improvement in box scar scars. For these types of widespread scars, I tend to use manual subcision together with a needle-free jet injector, and usually the effect is better. So on the same day, I use the manual subcision using cannula together with a needle-free jet injector. So also we can eliminate the edges of the border or borders of the scars more efficiently. Usually, manual subcision alone is not enough for ice pick or very well-defined box scar scars. So in that case, we can combine subcision with this technique. Again, for this patient had a very deep rolling scars overlapped with box scar scars and ice pick scars. So I used both techniques on the same day with filler, and there was very good reduction in scar depths, and also the edges or borders of the scars became much less obvious. So this patient also had a very deep scarring on the temporal area. So this kind of scar is very responsive to manual subcision, we all know. But also he had a texture change and also thinning of the skin. So to correct texture change, I used the CureJet together, and with the PDLLA and the needle-free jet injector, there was very good results with 1 session. Again, for this kind of widespread scar, usually this needle-free jet injector alone is not enough. So make more to have better results. I combined filler plus subcision, and that was very good results. So how about for the postoperative scar? So it's quite effective also. So he had a very deep scarring on the tip of the nose after the biopsy. So he came to my practice because the previous doctor knew the technology of a needle-free jet injector. So actually this patient asked me to do just a needle-free jet injector. But this patient had a volume loss, so I decided to use subcision plus filler together with with a needle-free jet injector, and there was very good result. So for this kind of the deep scarring, it's better to restore the volume. So I tend to use a filler injection together with needle-free jet injector. For this patient, it's a very complicated case. So he had elevation and also whitish change on the center of the scar, and also the entire area was depressed. So first I used a manual injection of a PDLLA 3 sessions, but it couldn't make correction for texture change. So I decided to use needle-free jet injectors, and there was also a very good result. And also needle-free jet injector kind of remodeled the scar itself, and there was a much better textural feature after the treatment. This patient had depressed and also the kind of obvious white scar after facelift, and she cared about the depression. So I actually suggested subcision first, but she didn't like the downtime and the risks. So I used a needle-free jet injector, and with one session, also the volume was restored and the texture change became better. So how about wrinkles? For these kind of horizontal necklines or forehead lines, this technique is quite effective. Okay, so I used as 2 sessions, and there was very clear result. And usually with needle-free jet injector, this doesn't recur. Also, we can use a filler injection, and it's very effective with one session, but it recurs in 6 to 12 months usually. But with a needle-free jet injector, recurrence rate is much lower because we can remodel the wrinkle tissue and also the scar tissue. Again, for horizontal lines, I used 6 sessions of this needle-free jet injector, and the horizontal lines became much less obvious. And also, he had scattered boxcar scars on the forehead, and also I treated them together, and they were almost gone. So how about pigmentation? This is a technique. I use a distant mode for the periorbital area. It's very safe. It causes some pinpoint bleeding, but usually downtime is usually 2 to 3 days with this technique. I use PDLLA material targeting pigmentation, and there was very good results. You can use any type of material like a tranexamic acid or glutathione, and we can achieve very good results. How about for hair loss? This is a technique to treat hair loss. This is the distance shot. So usually downtime is minimal, like a few days of redness. And this is a result. Also, we can do microneedling technique with exosome. Also, it's effective. But with this one, it's easier actually because with a distant mode, we don't need to do a needling for the scalp. So from the distant shot, it's very easy to treat the scalp. So I used the exosome, and with 3 sessions, there was very good result for female pattern hair loss. Usually, somehow, female type is more responsive to treatment rather than androgenic alopecia. But he had androgenic alopecia on the vertex area, and it was very responsive to treatment of needle-free jet injector with minoxidil. So this is takeaways from my session. So needle-free jet injector is a very versatile, powerful tool which can treat pores, wrinkles, and also the scars. And also downtime is very minimal if we take such distance from the superficial skin. For scar revision, it's better to hit the skin strongly, so I use a direct contact shots. In that time, usually the downtime is 1 to 2 weeks of redness, but it's much shorter compared with laser resurfacing or TCA cross. And the results are often better compared with a manual injection. As I showed you, for postoperative scars or acne scar, some patients already tried manual injection of PDLLA in other clinics, but they came to my clinic, and with a needle-free jet injector, I achieved a much better results. And with manual injection of like a PDLA or CAHA, it works, but it recurs usually. But with a needle-free jet injector, we can remodel the scar itself. So usually it doesn't recur so much. So that's a good point if we use a needle-free jet injector. And also we can combine a needle-free jet injector with any type of treatment. So I frequently use vascular laser together with this technique for rosacea patients because they have both redness and also pore dilation. And sometimes I use for rejuvenation, I use this technique with RF tightening. So we can combine any type of devices or injectables and enhance the efficacy. So we can say this is a very versatile tool, and it's majorly used now, usually used in Korea and Japan, but I hope it will be widely used, and we'll share the knowledge in the future. Thank you.
Okay. Good morning, everyone. I'm Dr. Hafizah Patan Rashid, and I'm dermatologist from Jakarta, Indonesia. So today I would like to share about the literature study for neurocutaneous determinants of treatment response following energy-based device procedures in skin of color. In daily practice, especially in skin of color, we often see something very familiar. So two patients may receive the same treatments with appropriate parameters, but their recovery response can be very different. So today we would like to change the discussions from only what parameters do we use to also how does the skin biologically respond and recover. So I have no conflict of interest related to these presentations. So classical patterns: two patients with similar indications and phototype receive the comparable EBD input, and then one patient recovers smoothly with minimal inflammations, no pigmentary change, but another patient may develop prolonged erythema, delayed barrier recovery, pigmentary change, and lower treatment tolerance. So this tells us that the outcome is not determined only by what we deliver into the skin. So traditionally, we explain the response variability through phototype, melanocyte reactivity, inflammations, and device parameters. This is correct, but it may not be complete, of course. The neurocutaneous view adds brain-skin axis and recovery biology. So instead of only asking, is this parameter safe? We also ask, is this skin biologically ready to recover from the controlled injury? So the EBD outcome itself is not explained by physics alone. So we deliver energy through device selections, parameters, endpoints, but after that, the skin must recover through inflammations, control, barrier repair, pigment regulations, and wound healing. So this recovery response may be influenced by stress burden, sleep quality, hypothalamic, pituitary, adrenal axis activations, and neuroimmune signaling. So the outcome is shaped by both procedural input and biologic recovery response. So then the brain-skin axis helps us to understand this. After the controlled injury, the skin does not recover in isolations. It recovers within a neuroendocrine immune environment, and three pathways are clinically relevant here. So the first one is HPA axis activations, and then peripheral neurogenic signaling, and then the skin recovery response. So these pathways may influence the inflammations, barrier functions, wound healing, and the melanogenesis. So before the procedure even starts, the patients may already be in a stress milieu. So psychological or physical stress can activate the hypothalamus, leading to the CRH, ACTH, and adrenal release of cortisol and catecholamines. Clinically, this matters because the skin we treat may not be a neutral canvas, right? So it may be biologically primed toward the neuroimmune and pigmentary reactivity before even the energy touched the skin. So the skin itself also has its own local stress response systems. The controlled procedural injury from the EBD can act as a local biologic stressor. Keratinocyte, melanocyte, sebocyte, and immune cells may participate in local CRH and POMC derived signaling. This means EBD does not only create controlled tissue injury, it may also activate the local neuroendocrine immune response inside the skin. Then another key pathway is the neurogenic inflammations. So after physical or thermal stimulations, sensory nerves may release the neuropeptides such as substance P and CGRP. These mediators may activate the muscles, vascular reactivity, cytokine release, and inflammatory amplifications. And of course, in skin of color, this is important because prolonged inflammations can increase the risk of getting PIH. And this is the POMC connections. Controlled procedural injury may activate the melanogenic stress pathways. The POMC-derived peptides, including ACTH and alpha MSH, can stimulate the melanogenesis through melanocortin signaling. In skin of color, where melanogenesis is highly inflammation sensitive, this may increase the susceptibility to PIH after the EBD-induced injury. So we can say that a PIH is not only a pigment problem, of course, it is also an inflammations and recovery biology problem. And here we see the vascular side of neurogenic inflammations. So the EBD-induced controlled injury may activate the sensory nerves and release these neuropeptides. The substance P here may interact with mast cells and vascular permeability, while the CGRP is associated with vasodilations. So clinically, this may help explain why some patients develop prolonged erythema, edema, sensitivity, or reactive recovery despite appropriate EBD parameters. Then the barrier vulnerability is another important determinant. Stress-related cortisol signaling may compromise epidermal barrier repair after the controlled injury. So if the barrier recovers well, we can see the keratinocyte recovery, lipid restoration, and the reepithelializations. But if the barrier is compromised, recovery may become slower, more sensitive, more reactive. So in skin of color, again, prolonged barrier disruptions may also prolong the inflammations and pigmentary risk. So the next one, the stress-related mediators here may also influence the wound healing. So the cortisol, the CRH, and stress-related signaling may influence the matrix remodeling and extracellular matrix regulations, potentially influencing collagen organizations. And then also the catecholamine-mediated vasoconstrictions may reduce local perfusions and oxygen availability, affecting the tissue repair and inflammatory resolutions. This is relevant for some EBD procedures like fractional or resurfacings, where the final result is not only depend on the injury creation itself, but also the quality of the remodeling. So if we summarize the possible mediator to outcome associations, the central HPA axis may prime inflammatory and pigmentary reactivity, then the POMC and alpha MSH may increase the melanocyte activations and PIH susceptibility. Then the substance P and CGRP may contribute to prolonged erythema, edema, and sensitivity. Cortisol and CRH may influence the barrier recovery and remodeling. And this framework, of course, does not replace the conventional EBD planning. It refines how we assess, and we assess risk and prepare the skin. Then the last one, clinically, this translates into 3 steps. First, the patient selections. We have to assess the inflammation's barrier status, previous PIH, see how the sleep or stress burden in the patients, and recovery phenotype. The second one, recovery optimizations, how we support the barrier repair, reduce irritations, optimize timing, and control inflammatory burden before the treatment. And the third one, the targeted energy delivery. Then we proceed with appropriate device selections, conservative parameters when needed, clear clinical endpoint, and also the structured post-procedure care. So remember, in skin of color, of course, the predictable EBD outcomes require more than correct parameters. So they also require understanding the biology of the recovery itself. So thank you for your attention.
Hello, everyone. It's a pleasure to be here. I'm going to start being very direct about this. This is a kind of patient that I'm not going to treat. The patient that come with swollen face, the patient that come with erythema, very strong erythema, the patient that come with probably dysbiosis, patient that come with active acne. I'm Dr. Daphne Pupo. I'm coming from Palma de Mallorca, Spain. And this is the kind of patient that arrived to my clinic and want to start with the treatment right away. And I told them, no, we can't start today. And it's very important that we understand the influence of the microbiome in the skin treatment that we are going to do in our daily practice. The comprehensive patient approach phases is come from the diagnosis, active treatment, recovery, and relapse prevention. Even if we are treating the patient just for lips, under eye treatments, we need to think about what are the functional aesthetic checklists that we need to do in the patients. And there are the 10 mandatory for me: sleep, digestion, energy, contraceptives, supplements, exercise, rest and weight, response to previous treatment. Even if the patient just comes from a lip filler treatment or under eye treatment, so we need to think about these checkpoints, because there are red flags that we need to think when the patient arrives. The red flag that we need to look at it is easy weight gain, when the patient have inflammatory diet, when the patient have unsupervised fasting, but that explained with fatigue, unexplained weight loss, persistent postprandial bloating. How many of you don't have when the patient comes to the clinic unbloated? I feel like, so that is the sickness that we need to look at it. And let me introduce you to Elisa. Elisa, she's a patient of mine. She's 40 years old, and she is under a divorce, under stress. She arrived to the clinic, and she was like with several complaints. She wanted to look more younger. She wanted to look more sensual. But Elisa told us in this screen that we did at the beginning that she has a hypothyroidism, and also Elisa has seen the symptoms overview: hair loss, inflammation, lack of energy, fatigue. But she wants to look younger and sensual. So what we can do if we are in an aesthetic clinic? So we look at Elisa and the dietary habits that she has. She has a daily dairy products. She is taking gluten, and she has like a diet without any restriction. Good for her. But previous aesthetic treatment, she always tell us, I have like migration, lip filler migration. I have swelling after my treatments. I have a very long time for recovery. So that's why when we see Elisa, we need to think about what treatment we can do without symptoms, what kind of paraclinical tests. if the patient have like alopecia, acne, or rosacea, or if the patient are under inflammation. This is the test that we order at the clinic before I start with any treatment. Let's go to look at Elisa, what test that she has. If you look at her, we can see that we have like the triglycerides, the vitamin D that is very low for her in the functional level. We can see also the fasting glucose is in the limit as well. And on her, we can see as well that we have a PCR in 1 in this moment, and we have as well that another thing that is very interesting is that the hormonal profile in Elisa. So we can think that on the ferritin level as well and the vitamin 12. So we can think that Elisa is under inflammation, and also Elisa has dysbiosis because she has medical record. So what are the red flags for her here? Sleep stress, chronic inflammation, metabolism, digestion, absorption, low micronutrients, and all that we can see it in the clinical evidence. When we diagnose it, when we look at the patients, we can see all these small details that are important. Because if Elisa wants to do the treatment, how I'm going to plan it? What we can do the same day? We can do neuromodulator, we can do facials, red light, facial lymph drainage is okay. But we should wait 15 to 20 days for no ablative laser, for microneedling, intradermal, and superficial peeling. And we should wait 1 month for polynucleotides, biostimulator, ablative laser, and microneedling. And we should wait 3 months, almost 2 months, for fillers. Because if not, Elisa is going to have migration, she's going to have a slow process to recover. And us, as aesthetic doctors, as dermatologists, as surgeons, we should work in these three important main things for me. Core physiological health, lifestyle, integrative aesthetic health. This is the most important when we are looking about the daily practice, the gut, the hormones, the physical activity, because when we think about the gut-skin axis, we know that we have different pathways, and these different pathways can be because the immune system, the metabolic pathway, and the external elements that we have. And we can work with probiotics, prebiotics, because one of the last paper that we have show us how the impact of the skin microbiome in the wrinkle formation. And we can see in the young skin, we have more Corynebacterius, acne, and more lactobacillus. And what happened in the ages skin is we have more wrinkles because the balance between them starts changing. So that's why one of the main strategies that we are going to use is balance the microbiome in the patients. What we did in Elisa, first active treatments. The active treatment that we have intraluminal antibiotics, herbal supplements, and intestinal motility support. So this is the active treatment that we do, and then we are going to start with a low food map diet for the next 6 to 8 weeks before any aesthetic treatment. For recovery and relapse prevention, in Elisa, we are going to do the 5 probiotics, and these are the main probiotics that we are using: the gradual reduction of eliminated food, chronic distress management, and intestinal mucus restoration, with the supplementation that we are using more than antibiotics. One of the things that we are combining is not just the oral probiotics, it's also probiotics for topical use, because we can see with these 3 kind of probiotics, we can reduce skin inflammation, improve skin hydration and barrier function, and we can reduce the collagen and elastin degradation. So it's not just working internally, it's also working in the external look of the skin. In the clinic, even if we know that we still have a lack of evidence for IV therapy, we use IV therapy with some of the vitamins for the patient that have a very high dysbiosis, and thermotherapy, cryotherapy, and nutraceuticals as well. So let's go to see Elisa. What happened after all this approach on her? So this is Elisa, and we recommend to her zinc, quercetin, glutamine, probiotics, ubiquinol, detox diet. We did a contrast therapy for her. Exercise in her case was yoga, sleep with all the sleep recommendations that we give to her, and the aesthetic treatment. 2 months later, collagen inductor and facial harmonization. And we can see why we can work with the skin resilience, because it's the framework, internal optimization, lifestyle anchor, and external support. Because at the end this is our daily practice: functional medicine questionnaire, analytics, genetic tests, physical exam, nutraceuticals, aesthetic medical treatment, and functional treatment. This is what we should do and how we should approach all the patients in our daily practice. Thank you very much.
hi. Thank you. So kind. Okay, can I? So, hello everybody, good morning. I'm Rieko Tsubauchi from Ginza Skin Clinic in Tokyo, Japan. Today, I'd like to present a novel concept for the treatment of sunken eye. Traditionally, the upper eyelid hollowing has been treated with filler like HA or otherwise fat, but however, these approaches do not address the underlying aging changes or structural changes. So in this presentation, I've proposed a new biomechanical model suggesting that the restoration of the orbicularis oculi muscle may improve sunken eyes through structural restoring rather than just simple filling. I'd like to disclose that I'm serving as a KOL for BTL Japan. Okay, so this is my patient. Here's a before and after images of a patient treated with a device that simultaneously delivers RF and high face for mid-face lifting, so mid-face lifting only. And what caught my attention was that the result appeared to extend beyond simple lifting, creating a younger and fresher overall appearance. And on closer examination, we realized that this rejuvenated appearance was driven by improvement in two key features: reduced lower eyelid bulging. We have this, okay, that's fine. I think you can find it, and reduced upper eyelid hollowing. So it was quite obvious. This same phenomenon was observed in another patient, also treated with for mid-cheek lifting. And the most striking change was actually in the periorbital region rather than mid-cheek lifting. And the overall appearance around the eyes become noticeably more youthful, and surprisingly, the superior sulcus hollowing located far from the treatment area also improved. This unexpected finding led us to investigate the potential role of the orbicularis oculi muscle in sunken eye rejuvenation. So FSG applicator was originally designed to target the mid-face elevator muscles, zygomatics major and zygomatics minor, and rhizolius, like this. But we often observe that orbicularis oculi have been contracted simultaneously. To understand this phenomenon, firstly, we need to review the aging of the orbital unit. So skeletal changes include maxillary retrorusion, orbital aperture enlargement, and fat compartment changes include roof atrophy and orbital fat displacement. And soft tissue changes include skin laxity and septal laxity, and orbicularis oculi thinning, and also fatty infiltration. Okay, so Okuda and her colleague has demonstrated the orbicularis oculi thickness decreased significantly with age. And most importantly, thinner orbicularis oculi muscle were associated with greater orbital fat protrusion. So these findings suggest that the orbicularis oculi muscle functions not only as a muscle of facial expression, but also as a supporting structure that helps maintain orbital anatomy. Recently, Gomi and his colleague reported a positive correlation between age and sunken upper eyelid. Okay, so briefly, this is a kind of schematic representation of the upper eyelid in normal and sunken eyes with age. So you could see red, and red line here. So this is oblique muscle, okay? So I go back to, again, MRI images. So Gomit's MRI study provided additional insight. And they demonstrated that concave eyes tend to increase with age. And there's correlation with the area of concave rate high with orbicularis oculi muscle thickness. And they found out that it also concave eyes rate with the position of eye center within the eye hole, and vertically and also horizontally. So the position of eyeball is changed with aging, which was found by the study. So how does oblique oculi restoration with HIFS and RF improve sunken eyes? So we raised two hypotheses. Hypothesis 1, internal pressure restoration. So this treatment would increase orbital retainment, posterior repositioning of protruding lower orbital fat, and also increased intraorbital pressure. So like this, when you press here, you will notice the changes within the hollowing, right? So this, I suppose, this treatment would help this change. So it would be resulting in reducing baggy eye, improved, and superior sulcus hollowing. Hypothesis 2, it's more focusing on upper eyelid portion of orbicularis oculi muscle. So this is upper eyelid myo restoration. So this is rather simply, this treatment increased soft tissue volume and improved tissue support and enhanced upper eyelid contour, and it is resulting in reduced superior sulcus hollowing. So there's another applicator with EmPhase. This is especially designed for here, an eye area. So it comes with HIFS underneath. So this EmPhase applicator should, we suppose, so this applicator should more improve this phenomenon. And I started to review all the cases. So more or less, the changes were subtle, but the pattern was always remarkably consistent. So again and again, improvement to lower eyelid backs was accompanied by improvement of, superior sulcus hollowing, like this. Sorry. So clinically, improvement of upper eyelid hollowing was observed in the vast majority of patients treated with simultaneous RF and HIFS for under-eye rejuvenation. And notably, improvement was also observed in some patients, even after a single treatment session at 1 month follow-up, not immediate after, after some time. It has been rejuvenated. And we noticed that, sometimes, patients don't react. Muscle contraction doesn't come up very clearly with stimulation. But in these cases, the changes seem to be a little bit, smaller compared to the patient who has rather, visible pull-ups of orbital fat and also, a good contraction by stimulation. Okay, so again, this is a very recent study. So this is a half-split study endorsed our findings, which endorsed our findings. So facial neuromuscular electrical stimulation can increase the orbicularis oculi muscle and change the fat herniation. So you can see this findings with MRI images. So the left side, which is not treated, has give no change, but otherwise the right side, which has been treated with electrical stimulation, it gave change in orbicularis oculi muscle thickness, like plus 1.4 millimeter around, and it will reduce the protrusion of under eye fat, orbital fat. It's like -4 or 4.5. So you could notice okay, so this is done. Interesting, it's done by home use, device. So they continue 3 times a week for up to 8 weeks. So after a picture has been done immediately after 8 weeks treatment. So I really doubt that it could be just a contractions and continuing contraction itself. But interesting thing I found is the image with an MRI. You could see the sunken eye, or otherwise concave shape, has been changed, right? And also the structure, of whitish structure. Can you see? Can you recognize orbicularis oculi? On the left side picture, the curve, the orbicularis oculi muscle comes with the kind of curve, concave shape, and after the continuous, treatment, we will see the concave improves a lot with, the structure of orbicularis oculi improved. Okay, so we haven't done any, CT or MRI treatment finding, but today I raised this new approach from fitting to repositioning. So myorestoration through rejuvenation of the orbicularis oculi muscle and also the orbital unit may shift the treatment paradigm from just a fitting to structural restoration in sunken eyes. Thank you very much. And I will welcome you all to Japan, MWC Japan, in this September. Thank you.
Hello, everyone. I am Dr. Magali Ocon, dermatologist from Rosario, Argentina. And today, I will share a case report about periocular rejuvenation through a multi-level structural approach. A quick disclosure before we continue. This work was not supported by any direct or indirect funding. And let's start this lecture with this concept. We must understand the gaze as a structural unit. The periocular region depends on the interactions of all these anatomical areas: the eyebrow, the temple, the supraorbital hollow, the orbit, the infraorbital area, and the eyelid tip junction. All of these structures work together to shape and support the gaze. And we know that when one or more of these anatomical areas are compromised, the perception of the gaze also changes. Here is Sandra, my patient. He is 58 years old. She had history of upper blepharoplasty performed 2 years earlier, and she came to my office because she felt that after surgery, she felt that her eyebrow asymmetry was even more noticeable, and her tired appearance too. And so during the evaluation, I started questioning why the result was still perceived as incomplete. And I realized that the problem was not located only in the eyelid, but in the relationship between all the structures, as we can see. So I evaluated her with vector analysis, and the grayscale confirmed that she had asymmetry in the eyebrow position, her asymmetry in the temporal fossa, her supraorbital volume loss, and her mid-face structural imbalance. And the objective here was not simply to treat isolated areas, but to restore balance and integration throughout the periocular region. So for this reason, I designed a multi-level structural approach to treating different anatomical levels to restore support, improve vector balance, and integrate the periocular region as a whole. And here the vector dynamics become clinically important. The idea was not only to replace volume, but to restore support in the right direction. As we can see, the temporal area provides a lateral support. The mid-face creates a vertical support vector for the lower eyelid and the eyelidic junction. And the supraorbital region helps frame the upper periocular area. This allows us to treat the periocular region as a connected structural unit. These vectors inspired the treatment plan for my patient. So, on day 0, I injected incobotulinum toxin A, and on day 30, I selected 2 different profiles of high hyaluronic acid fillers and 1 biostimulator as calcium hydroxyapatite, and I did the follow-up on day 60 and 90. On day 0, as I referred, incobotulinum toxin A adapted according to her muscular dynamics and eyebrow asymmetry, improved the position of the brows, and create more balanced upper periocular frame. Here we can see the marking was designed to reduce the activity of the medial frontalis area and optimize the lateral frontalis action. And I added some points to improve symmetry. And then these areas were treated to restore upper facial support, and mid-face support was improved to optimize the eyelidic transition and periocular integration. The treatment followed established lifting and repositioning vectors. As the result, I evaluated her with standardized clinical photography with vector analysis and global static scale on day 0, 30, 60, and 90. As we can observe, improved periocular integration and overall facial balance with a softer and more harmonious gaze. We can also see better eyebrow symmetry and improved supraorbital contour and a smoother eyelidic transition. The result preserves her natural expression. With the gaze follow-up, Sandra rated her outcome on day 30 as moderate improvement, and on day 60, after the hyaluronic acid and biostimulator, she rated her outcome as much better. About safety profiles, hematomas and edema were observed but resolved spontaneously after 30 days without intervention. No serious adverse events were observed. And let's read together these home messages. Periocular rejuvenation is not only about treating the eyelid. It requires structural support, vector modulation, compartment integration, and patient-specific planning. And the last one, we must understand the periocular region as a single structural unit, allow us to achieve more harmonious results. Here are the references, and that's all from me today. Thank you so much for listening.
for a while. They're fixing my keynotes. Okay. What happened? I think it's okay. Not this one. Your pointer. Your pointer. Okay, good morning, everyone. I'm Dr. Filuteo from the Philippines, a dermatologist. Today, we'll take a look at a systematic approach to full face rejuvenation using the MD codes. My disclosures are the following. So the MD codes were developed by Dr. De Maio, a plastic surgeon in Brazil, and it serves as a standardized universal language that codifies our injection depth, the technique, and the active number. So I will present to you a 65-year-old filler-naive Asian female with the following deformity. She has tear trough deformity, malar volume loss, deep nasolabial folds, and heavy marionette lines at baseline, and full face rejuvenation at the right. So to review the anatomy, let's move to the retaining ligaments. So we have here the tear trough ligament, which is continuous with the lower lamella of the oral retaining ligament, and this is your upper lamella of the oral retaining ligament. The eye bag is not actually an extra fat, but failure of the containment of these ligaments as we age. Okay, let's review also the 5 layers of the skin, which are really basic. So here we have the superficial, the skin, the second layer, which is your superficial fat, the muscle layer, and your deep subcutaneous layer, and your periosteum. So mostly we will inject on layer 4 and 5. So from this dissection, we can see that we can trace the skin here, there, and your superficial fat layer, and your very thin orbicularis oculi muscle. So this is your SOOF. So this is where we will inject. So we have your lateral SOOF here and your medial SOOF. Of course, we have to know the danger zone. So we have to know where the infraorbital foramen is, which is 7 millimeter to 10 millimeter below the infraorbital rim. Okay, we have also the primary vessels of the jawline and chin, the facial artery here. Okay, the facial artery here. Okay, and posterior to it is your facial vein, your superior labial, and your inferior labial artery. So we have also your submental artery, which is alongside or underside the jawline toward the chin, and your mental artery. So we have to know also your mental foramen, which is vertically with it aligns vertically with the second premolar, roughly in line with your oral commissures. Okay, so to build the structural foundation, we have to know the cheek MD codes, and we always do this first. So we have the CK1 and CK3, which we will always use for periorbital rejuvenation. Okay, the CK1 is your zygomatic arch. It anchors the lateral midface. Your CK3 is your anteromedial cheek. It is the apex of your cheek and can be addressed in, across 3 layers: your supraperiosteal plane, your deep malar fat pad, and your SOOF. So with our patient, we will approach it through the deep malar fat pad and your SOOF. So to identify your CK1, you have to mark the temporozygomatic suture and place 2 additional marks, 1 cm anteriorly and 1 cm posteriorly. This creates a 3-point supraperiosteal landing zone at 0.1 ml per point. So as we can see here, after a total volume of 0.3 ml, there's already narrowing of your facial silhouette here. There's already standardization, and it results in your superior and lateral migration of your malar apex. Okay, we go to your tear trough codes. We have your medial, lateral, central, lateral, and your medial infraorbital, infraorbital tear trough codes. So the injection technique across your tear trough, you target only 0.01 ml to 0.03 of your product per single pass. So you only deliver here micro droplets of the product just below your infraorbital rim. So we go to the Chin MD codes, but we will discuss the to increase your vertical height of the chin, you don't only inject on your chin apex here, but also on your mentolabial sulcus. So the jawline codes, finally, we have your jawline codes from J1 to JW5. So moving to the patient, we have here a 65-year-old female. We injected on the CK1, which is your zygomatic arch, 0.1 ml times 3 boluses, and on your anterior medial cheek with 0.7 ml using cannula on the layer of the medial malar fat pad here. Okay, that's layer 4. That's on the first session. And we can see after 9 days, there's already periorbital restoration, optimized malar apex projection, softening of your nasolabial folds, and your lid-cheek junction already improved. Okay, your clinical anatomy of CK4, that's here, there. So for session 2, we did the refinement. We delivered 2 ml of your product at 1 ml per side using HA 20 milligrams per ml. Again, we injected again CK1 because we have to anchor. So that will be again 0.1 times 3 boluses. And this time, the CK3, we injected your SUF only with 0.2 ml of your product. And the CK4, 0.5 ml of the product, subcutaneous threading. Okay, for session 3, we did the periorbital refinement using HA 15 milligrams per ml, of course, on your deep supraperiosteal layer. So we delivered 0.5 ml of your product per side. We can see that this is your, of course, the area of your infraorbital foramen. So we only injected 0.1 here. For session 3, we delivered 2 ml of the product using HA 20 milligrams per ml. So we can see that we always start with the first code, which is your C1. We actually delivered 0.7 ml per side. And for C2, which is your chin apex, we delivered 0.3 ml per side. So session 3, we also injected 1 ml, HA 20 milligrams per ml. This time I did not follow the active numbers because I'm only limited to 1 ml. Okay, so for C3, I just injected 0.1 per side. And for the Pogonian, it was only 0.2, and your C6 was injected with 0.3 ml per side. The C6 is actually your triangle here, okay? And later, I will show you that this is your JW4, which we will inject later, okay? Or I mean, we will show you later, okay? So from here, the jawline codes, we use 25 milligrams of your HA at 1.5 ml per side, okay? So at J1 here, your mandibular angle, we injected 0.5, supraperiosteal bolus. Your JW4 here, and 5, we injected 1 ml per side, subcutaneous placement. Okay, for refinement and hydration with blending, we use Skin Booster at 12 milligrams per ml and 0.5 ml per side. It was intradermal, mid to deep dermis delivery. So over the progressive restoration of facial harmony, we can see that there is already improvement of the periorbital area. So this is, I would like to share that on this area, you can use Skin Booster, age 8, 12 milligrams per ml. It's very good. Okay. So my abstract is only until August 9, but after even 36 months of her session, the structural integrity of the lower and mid face has not collapsed. So my key takeaways, the golden rules, the foundation rule: never treat the tear trough directly until the cheeks are supported. Aim for 80% correction in the periorbital zone. Underfilling is a simple tweak. Overfilling leads to complication like Tyndall effect or malar edema. The SOOF safety rule: treat the SOOF as your safety zone. If you can see the shape of your cannula, you are too superficial. Okay, think of the chin and jawline codes as a single unit. Bridge the transition from the mandibular angle to the chin to create a continuous sharp border. Establish the chin and jawline anchors on the bone, then use subcutaneous layers to transition smoothly. Mentalis check: if the patient has a pebbled chin, use a neuromodulator first. Active numbers are non-negotiable. The active number is the minimum therapeutic dose to achieve the true mechanical lift. Always aspirate for 5 to 10 seconds. Re-aspirate if needle position shifts. Thank you so much.
Good morning, everyone. My next lecture is non-cross-linked high molecular weight hyaluronic acid for non-surgical facelift. I'm Dr. Joseph Andre Bangalo, an aesthetic medicine physician from the Philippines. Here are my disclosures. We've been talking about hyaluronic acid for the past few days, and we're very familiar with its natural behavior, characteristics, whether it's in a filler form or in a skin booster form, or as a biostimulator. Today, I will emphasize how hyaluronic acid is being categorized as a biomodulator. But what is biomodulation? It is defined as a modification of biologic response. And with hyaluronic acid, it is considered as a biomodulator, for it possesses different features such as for lubrication, moisture, matrix structure, and steric interactions. For cell interactions, it's for differentiation, proliferation, development, and recognitions. It also acts as an external cytoskeleton, modifying and controlling the shape of the cell, and it also has anti-inflammatory and immunomodulatory effects. So hyaluronic acid performs its biological function either as a structural passive molecule or as a signaling molecule. As a structural passive molecule, the passive mechanism of hyaluronic acid is related to the physiochemical properties of high molecular weight hyaluronic acid. Due to its macromolecular size, marked hygroscopicity, and viscoelasticity, HA is capable of modulating tissue hydration, osmotic balance, and being a component of the extracellular matrix. As a signaling molecule, Its molecular weight, location, and specific cell factors determine opposing factors. So for example, low molecular weight HA has pro-inflammatory properties, whereas a high molecular weight HA has anti-inflammatory properties. Here we see that as the molecular weight of HA increases, its response in relation to inflammation also changes. So hyaluronic acid also interacts with extracellular matrix and other cellular receptors like your CD44 that suppresses pro-inflammatory cytokines, synthesis of your MMP, and prostaglandin E2. It forms a protective HA layer on the cell surface, which can mask cell death receptors and consequently prevent the cell from undergoing apoptosis. It also interacts with the receptor for HA-mediated motility, or the RHAM, which regulates cell responses to growth factors and plays a role in cell migration, particularly of fibroblasts. It also modulates cell motility, wound healing, and signal transduction. It also interacts with intercellular adhesion molecule 1, which functions as an adhesion cell molecule to balance inflammatory activation. Now let us emphasize the interaction of HA with the PPAR gamma, or the peroxisome proliferator activated receptor gamma, which is present in different layers of the skin and beyond. So for the epidermis, its interaction increases. Elastin production increases type 1, 3, 4, and 7 collagen production. For the dermis, its interaction increases elastin production, increases type 1 and 3 collagen production, and improvement and maintenance of skin hydration and elasticity. It also increases adipose-derived stem cells differentiation into adipose cell. So for the muscle tissue, it increases muscle cells viability and proliferation, increases resistance to oxidative stress, and regenerative effect on muscle cells. So for the bone, it increases osteoblast viability and proliferation, and there's improvement of bone tissue mineralization and regeneration. So given the different interactions and effects of hyaluronic acid on different structures, let me share how a combination of high and very high molecular weight HA that has two kinds of non-cross-linked hyaluronic acid, one that is 1.8 megadaltons and a 4 megadalton injection deep into the dermis. So combination high and very high molecular weight HA may improve skin firmness, deep hydration, facial remodeling, dermo-hypodermal support, and skin lifting. But how can this combination produce skin lifting? Like in the concept of dermal fillers for skin lifting, we want to target the lateral portion of the face. But also here, we want to strengthen the retaining ligaments to give that natural lift. We will be focusing on the superior and inferior temporal septum, orbicularis retaining ligament, zygomatico-cutaneous ligament, lateral cheek septum, middle cheek ligament, and the mandibular retaining ligament. These are just some of the variations of injection points for us to visualize. Since the solution that I am using is 3 ml, I inject on 10 points per side of the face, and I use 0.15 ml per injection point. Depending on the physical assessment, we can inject in the temples along the zygomatico-cutaneous ligament, lateral cheek septum, mesenteric retaining ligament, and the mandibular retaining ligament. However, at the end of the day, as long as we know the principle behind the treatment, we can modify these injection points based on our physical assessment of the patient. Here, if there's no temple hollowness, but there is the presence of jowls, we can modify the injection points. So take this as an example of a 52-year-old male. I injected the mid and the lower face except for the temples, since there is no visible hollowing. Instead, I injected the piriform space just to create an anchor at the nasolabial fold. I did 2 sessions for this patient at 1-month interval for each treatment. During the treatment, I used a 3 ml syringe. I injected 0.15 ml on each point. Then I would press it until there's no longer the bump, It disperses the product vertically and horizontally, so this has a very minimal downtime. Using a medical grade skin analyzer, we analyzed the patient's skin and overall skin aging. Skin age prior to treatment was 52 years old, then down to 50 after the first session, and down to 49 after the second session. So this is a 72-year-old female. We did the treatment, since there is temporal hollowing, I did 3 points in the temple area, in the superior and inferior temporal septum, and 1 in the lateral orbicularis ligament. So before the treatment, skin age is 72. After 1 month, it's down to 71. And then 2 months after, or after the second session, it's down to 68. So the key takeaways: hyaluronic acid is also considered a biomodulator when the molecular weight is very high. High molecular weight HA may be given to a patient for the purpose of skin lifting when injected on the lateral aspect of the face along the lines of ligament. And the high molecular weight HA may be given in combination with other products like fillers, other skin boosters, and biostimulators. Thank you so much.
Buti na lang, kayo lang. Mabuhay from the Philippines. Yes. What do I do? Okay, and then this one? Yes. Okay, I'll look na lang at this one. Where do I look? Tinan mo, I need glasses na kasi. Hello, I'm Dr. Vicky Bello from the Philippines in the Bello Medical Group. Yay! And I'm going to be talking about the treatment of melasma using a combination of a 755 nanometer picosecond laser and a microneedling assisted delivery of several actives like niacinamide, tranexamic acid, GABA, and exosomes for melasma. I have no disclosures. So as we all know, melasma can be superficial, which looks like light brownish things, or it can be deep, which is maybe grayish black. And then it can be mixed, or it can be on top of a reddish layer. For the longest time, at least since I've been around so long, we used to treat melasma monotherapy using the gold standard of treating melasma, which was hydroquinone. But we soon realized that it wasn't a really good thing to do, and it kept coming back. So now we realize in the past few years that melasma is multifactorial, and therefore we should treat all the factors that cause melasma. So the objectives, I don't want to repeat my long title, but that's the primary objective. And the secondary, may glasses na ako, hindi pa ako makabasa. The secondary objectives are to assess the improvement in MASI scores, evaluate the changes in the melanin index, and we use the analysis of skin quality using the VISIA imaging, and determine patient satisfaction and safety. So methodology, the study is a prospective study. It lasted 3 months. Of course, all the patients had melasma. There were 15 people enrolled in the study. Their ages ranged from 20 to 50. And they were all Fitzpatrick 3 to 5. And the treatment schedule was the day they arrive, we do the treatment. And 1 month later, we do the second treatment. The third treatment is done at the second month. And then we wait 1 month before we evaluate them. So the results are really pretty good. All patients finished the whole treatment. There was progressive improvement every single time they came. In fact, your MASI score went down by 54%. Yes. And your melanin index went down by 32%. So the patient satisfaction rate is pretty high at 90%. 50% said they saw a pretty significant improvement, 40% saw moderate improvement. As far as the safety profile is concerned, aside from a little post-erythema and a little post-edema, which just subsided after a few hours, there was no PIH, no scarring, no problems really. So let's look at the results, right, closely. So here are some of the patients before and after. This one's so nice, I think. Before and after. I will know myself. Here's another before and after. You can see what a big difference. Yes.
If you don't talk.
I have to be here. You cannot hear? Oh, there. It's okay. Are you okay? So, multimodal synthesis approach. So as the conclusion is that of course it helps to use the picosecond laser, and I'd like to talk about the bioactives that we use. The tranexamic acid is, of course, it reduces hypermelanogenesis. The niacinamide is very, very calming. It stops the vascular reaction. The GABA is also calming and anti-inflammatory. And the exosomes are fixing, because the problem is the 5 things, right, which I kind of skipped earlier. Wait. So here we are with the 5 things that you have, the 5 things that cause melasma. Aside from, first of all, is the hyperactivity of the melanocytes, which increases the production of the melanocytes and its deposition. Number 2 is the reactive oxygen species, which can, be free radicals, which again can cause oxidative stress. The oxidative stress will increase your melanogenesis and increase the vascularity of your skin. Then we have the inflammation, which also increases melanogenesis and causes some changes in the vascularity. Then we have your vessels that are unstable. They're either hyperreactive or there's high angiogenesis, so there's an increase in the deposition of blood vessels, which makes the area red. So as long as the blood vessels are feeding the melasma patch, then you can't really get a good resolution of your melasma. And then we're talking about the dermal matrix and the extracellular membrane. What happens is there kind of breaks in the extracellular membrane. There's less collagen, elastin, and GAGs, and so the melanin can escape to the higher levels of the skin. So in conclusion, at Bello Medical Group anyway, it really results in very happy patients. The satisfaction rate is very high. There's hardly any side effects. The combination is extremely well tolerated. They're very comfortable. It's also very safe. So in conclusion, we should try the combination of the 755 nanometer picosecond laser and immediately do the microneedling. So you create a lot of little tunnels where the bioactives can penetrate. And that's basically it. Thank you.
You're not ready now?
Yeah, that's the one.
You are the next one.
Yeah, yeah. So keep the after. Yeah.
Good morning, everyone. Nice to meet you in Thailand. I'm from Myanmar originally, but now I'm doing my PhD here in Thailand. Today I'm gonna talk about node house treatment, Marrakech or mix. I think this is the new terminology. Nowadays it's popular in the cosmeceutical. So today I would like to share a little bit about that. So let me start with what is node house treatment. Also, so let me start what is treatment. It's not the treatment, it's the treatment. Okay, so what is the treatment? It's the treat and the treatment. Okay, so it's a non-surgical, minimally invasive procedure that offers the safety, natural enhancement for your appearance. So that means it should be non-surgical, and it must be minimally invasive procedure for your appearance. What about node house? Node house is like, it's not a toxin. It's not a toxin, but it works for the wrinkles. Usually for the wrinkles, we usually use the botulinum toxin. But nowadays we have so many modalities that can affect on the fine lines or the wrinkles. So we call the node house treatment. So node house treatment are the remedy for the fine lines and the wrinkle that mimic the effect of toxin without needing a needle. Needle-free, wrinkle-free skin treatment are called the node house treatment. So what are they? So classically, we have the botulinum toxin, and it's effective in 80% of the it's effective in 80% reduction after and 3 to 6 month duration. Everybody know about this one. What about other neurocosmetic alternative? Now the market is in the growing trend. You will see like 421 billion by 2030, and then so we should learn a little bit more about that. So this is the neuromuscular junction. As you see in the number 2 is the SNAP25. It's the action of the botulinum toxin. But nowadays we have the other molecule that can act on the neuromuscular junction. The first one is the number 1 is about the opioid receptor modulator. The second one is the SNAP28. The third one is the acetylcholine receptor. So these all add together so to inhibit the wrinkles like the botulinum toxin. So the most famous one about the node house treatment is acetylhexapeptide 8. I think it's available in most of the country. And according to the RCT, they found that after application of acetylhexapeptide 8 for the 4 weeks, and there will be around 50% reduction in the wrinkle. And so they said that it is safe and effective. So for myself, I also try like the pilot study, and I use for my forehead wrinkles, and after 4 weeks, and you will see like some visible improvement, and at the end of the 8 weeks, and then so you will see like reduction in the fine lines, only the topical treatment. Before that treatment, I avoid the botulinum toxin for around 6 months, and then later I started to apply, and you will see that wrinkle score is also reduced. And also now we are starting to use for the periorbital wrinkles, and then so we are working on about agile solution like the randomized control trial, but the study is ongoing and the final data is not available yet. And so this is the agile is number 2, is the same mechanism as the botulinum toxin. So let's move to about number 3. This is the acetylcholine receptor antagonist. If you can inhibit at that stage, and you can also have the effect like the Botox. Okay, so one of the interesting thing is about this one we call the Syncane. It is a synthetic venom, snake venom mimic, and then it's from the snake, Asian snake like that, and then so they extract and they use this for the wrinkle reduction, and then you will see that there will be 52% reduction in just 28 days, and then so it works well like the acetylhexapeptide, and so they are now getting popular regarding as the node house treatment. So this is my summary for the node house treatment. If you wish to choose any peptide for the topical, like the botulinum toxin, you can choose from any of these. The first 3 is like pre-synaptic, and then the other post-synaptic, and the last one is the add on the muscle. And you will also see the efficacy, and it's like 48.3%, 63%. But as I discussed earlier, for the botulinum toxin, it's more than 80% reduction. But here, the maximum will be around 63%. So in conclusion, these peptide, the topical peptide cannot substitute the botulinum toxin injection for sure. But if you wish to like the adjunctive effect, or if you wish to give your patient to take the action of the botulinum toxin longer, and then so you can complement with this kind of the topical treatment. So what about the consumer trend and the market insight? And then it's growing. The market of the peptide is growing day by day. And also you will see in this picture, the Adderall is the most popular one. And also there are a variety of the peptide available in different regions. And you will see that in the Barcelona and Spain, there are so many peptides in this region, and you can choose from any of these. And the Adderall will be the most important. The most popular one is the acetohexapeptide, okay? So another is about the other country. You will see like in the Netherlands, they use the snake derivative and the other, and this is from the plant. Myosinol is from the okra. It's from the plant, and then it's famous in the Germany. And also the other United States, and they have another kind of the peptide which work for the wrinkles. So how about if we combine all together different peptide which act on the pre-synaptic, synaptic, and the post-synaptic? If we combine together, there is a research paper. This is just for the topical application in the 56 participants, and they combine all these peptides with different kind of action, and they found that 100% of the patient respond well with that topical treatment. Yes, but improvement is not like satisfactory as in the Botox, but the patient have visible improvement in all the 56 patients. And regarding the safety, it's just a topical. They don't have effect like other, like the ptosis or the like other side effect of the botulinum toxin, and so the set is safe and also effective. So in conclusion, you will see that botulinum toxin is the first one, the standard treatment for the wrinkle reduction. But alternatively, you can choose the topical neurocosmetic for the reduction as well. But the maximum efficacy will be up to around 70%. Okay. And so in conclusion, so if you wish to choose the peptide, you can choose for the young age and early onset. And also, you can use as the A standard for your botulinum toxin. After you inject the toxin, and if you wish to extend the duration of your toxin, you can use together with the peptide. And another is about the alternative. Sometimes in the pregnancy neuromuscular disorder, they cannot use the botulinum toxin. And if they wish to reduce their fine line, and then so you can use alternative like these kind of the peptides. So the peptides nowadays is very popular, and also we can say that they offer non-toxic sustainable skincare solution, and also we have the visible clinical result, but they cannot compete with the botulinum toxin yet. So they can be used as an adjunctive, but not replace the botulinum toxin yet. So this is my key message for today, and thank you so much for listening.
So to begin. Okay. Hello everyone. I'm Guo Baowang from Department of Plastic and Cosmetic Surgery at the Tongji Hospital of Tongji University in Shanghai, China. Today, I'm honored to share our approach to anatomy-based facial contour filling in Asian patients using minimally invasive injection. This work is built on the FutureCo's aesthetic design system developed by my mentor, Professor Haiyan Cui, who is also the chairman of OPEC conference in China. Just a brief introduction about myself. I'm a plastic surgeon and associate researcher at Tongji Hospital. I'm a member of ISEPS, and I've published several SCI papers as a first author. I'd like to quickly acknowledge the key conferences for this talk. This first one paper is our paper. I wrote it in 2020, and where my mentor, Professor Cui, introduced the Future Codes aesthetic design system for Asian patients. This is the fundamental of everything I discussed today. And there is another paper published by Clinical Plastic Surgery in 2023, focusing on the minimally invasive approach to facial rejuvenation with an impact factor of 2.53. The impact factor is not very high, but this paper expanded on the clinical application of our aesthetic framework. Now, let me give you the big picture before we dive into the anatomy. The literature on East Asian aesthetic design is actually quite limited. That's exactly why Professor Cui developed the Future Codes aesthetic framework. Last year, our team built on this framework and developed a comprehensive facial contour feeling guide with recommended dosage for each side. And that's what I'll walk you through today. You can see the full table here. From the glabellar supraorbital ridge, we recommend 1 millimeter in total, through the nose, lips, chin, cheeks, all the way to the contour, the ear, the temples, and the jawline. Before we go into our protocol, I want to ground this in anatomy. Why is anatomy so important? When I was pursuing my PhD degree 10 years ago, I studied at the top anatomy research division in China, Fudan University. My professor always impressed these truths upon me. Anatomy is the very foundation of medicine and is the core basic skill for every surgeon who should master. So let's start with the fundamentals of from the 5 tissue layers to our face, including layer 1 is the skin, and the layer 2 is the subcutaneous layer. Layer 3 is the SMAS, the superficial muscular aponeurotic system. It separates the superficial fat from the deep fat. Layer 4 contains the retaining ligament and the deep fat compartments. And layer 5 is the periosteum and the bone. Here is the one thing I want you to remember. With every needle pass, you must know exactly which layer you are in. That is the difference between a safe injection and complications. Now, let's look more closely at the retaining ligament system and the SMAS. This is important because when you inject, the SMAS acts as a barrier. A product placed in the superficial layer behaves very different from one placed deep into the SMAS. This slide shows the work that really changed how we think about facial aging on facial fat compartment. As we grow older, our facial fat is not static. It's in a constant stage of dynamic change and redistribution. For specific, so aging is not just fat loss, it's fat redistribution. Superficial fat gets behavior, and on the other side, deep facial disappears. Our treatment strategy follows from this. Restore deep volume and manage superficial behavior. We may have different protocol for different layers. But it is not just the soft tissues that change. The bone changes too. The bone is alive. So Dr. Lambros showed us that with aging, the facial skeleton is changing and remodeling. And there are a few principles I want you to remember on the muscles on the right side. I can't overstate the importance of this slide. Vascular complications are the most feared adverse events in our field, and under every injection needs to know this danger zone code. The facial artery and its branches carry the highest risk for intravascular injection. The supratrochlear and the supraorbital vessels create a danger zone in the forehead, and the angular artery is a key vessel to watch in the nasal and medial canthal region. My rule is simple: always aspirate before you inject, and remember, safety first. Know exactly what depth you are in. All right, now let me bring all of this anatomy together into our clinical protocol for facial contour filling in Asian patients. I'll walk you through 3 key regions. First, for the temple. For the temple contour shaping along the hairline, we inject at 3 layers. One is a subcutaneous fat layer, and the mid-temporal fascia, and the periosteum. Sometimes, actually, injecting just above the periosteum is enough, sufficient. Just use a sharp needle. Use a sharp needle to push it all the way down until you hit the bone. Yeah. Then inject your filler. It is very safe and give you a real natural results. Yeah. For example, if you put it in the superficial, it will some bump. But if you put it just the periosteum, it's very deep, and the shape will very natural and safe. So even 3 layers I told you, you just use 1 layer. The periosteum for the temple is very safe. Yeah. And the second, the area around the pre-auricular region and the cheeks. We mostly use filler here to fix second cheeks, and we only inject into the subcutaneous fat layer, not too deep. And we only inject, don't go over 1 milliliter per side in 1 session. We just want to softly restore the cheek contour. Remember, our aim is subtle contour restoration rather than over correction for the cheeks. No over correction. Third, for the jawline area are also very famous. Our main goal here are lifting and sharpening the mandibular contour. Yeah, make it like balance. And for the subcutaneous injection, keep the total volume below 1 milliliter per side. When injecting periosteally, administer tiny boluses. The bottom line principle: different regions demand different layers. Temple requires a multiple layer approach, while cheek and jawline are primarily subcutaneously. Always aspiration, and remember safety first. And choose your needle or cannula based on the anatomical layer you are targeting. Okay, we are nearly finished. This is my article's picture, and here is our complete dosage reference table from our article publication. I won't read every number for it because the time is limited. You can capture this slide for your own reference, but let me highlight a few key points. For the because in this session we talk about the contour, so we skip the central facial side like the nose, the nasal base. We skip it. For the out facial contour, and this is where we can really transfer the face, and the ear can take 2 to 6 milliliter. For me, I can use just 1 milliliter hyaluronic acid to make the ear lift, and the temporal region 4 to 8 milliliter, and the mandibular contour 2 to 4 milliliters. These volumes create the structure framework that support everything else. What I want you to take away is this: the Future Code's aesthetic design method first help us to see what needs to be treated, and then this dosage guide helps us execute that treatment precise and more safely. And this is some clinical cases upon the protocol I mentioned above. Thank you very much for your attention.